Brugada's syndrome and sudden cardiac death. Petra Lovrik. Mentor, Asmagak Horvat. Petra Lovrik. Sudden cardiac death incidence, cases/year, survival worldwide. 3,000,000, 1%. US. 450,000, 5%. W. Europe. 400,000, 5%. Causes of sudden cardiac death. 80%, coronary artery disease. 15%, cardiomyopathy. 5%, other. Cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy. Arrhythmogenic right ventricular cardiomyopathy. Left ventricular non-compaction. Restrictive cardiomyopathy, cardiac channelopathies. Brugada syndrome. Long QT syndrome. Short QT syndrome. Idiopathic VF. Short couple torsades. Brugada syndrome. First described in 1992 in 8 patients with aborted sudden cardiac death. History since 1986, Brugada brothers. Brugada syndrome characterized by ECG findings of RBBB and persistent SAINT elevation in V1, V3. Structurally normal hearts. Propensity for life-threatening ventricular arrhythmias. J-point elevation. Brugada syndrome, ECG. Brugada syndrome, ECG. Typical electrocardiogram of Brugada syndrome. Note the pattern resembling a right bundle branch block, the PR prolongation and the SAINT elevation in leads V1 V3. Brugada syndrome, ECG. Brugada syndrome, ECG. Spontaneous polymorphic ventricular tachycardia recorded during monitoring in a patient with Brugada syndrome. The arrhythmias are fast and need DC shock to terminate. Brugada syndrome, clinical features. Unexpected sudden death. Syncope, seizures. Agonal nocturnal respirations. Affects male patients predominantly, 8-1. Cases reported worldwide. Brugada syndrome, incidence and distribution. Responsible for up to 50% of sudden death victims with structurally normal hearts in Thailand. Recognized in Asia for decades. Philippines, bang angat equals scream followed by sudden death during sleep. Thailand, late eye equals death during sleep. Japan, pokuri equals unexpected death during sleep. Brugada syndrome, ECG. 12-lead ECG during administration of amylin, 50 mg in 5 minutes. Brugada syndrome, ECG. 12-lead ECG during administration of amylin, 50 mg in 5 minutes. Note the progressive appearance of the SAINT elevation in V1 V3. Brugada syndrome, factors, drugs that enhance ECG pattern. Na plus channel blockers. Alpha agonists, vagotonic agents, beta blockers. Fever. Alcohol, cocaine. Severe ischemia. Tricyclic antidepressants, antihistaminics. Brugada syndrome, genetics. Autosomal dominant. 60 different mutations in the SCN5A, chromosome 3, gene have been linked to the syndrome. Failure of alpha subunit of sodium channel to express. Shift in voltage and time dependence on INR plus activation, inactivation or reactivation. Brugada syndrome, diagnosis. Symptoms, syncope, SCD, usually during sleep. Physical exam, normal. Family history, strong history of SCD. ECG, best test to identify Brugada patients. May require flecainide or procainamide to bring out typical findings. SAINT elevation, RBBB. Imaging tests, usually no underlying structural disease. Stress tests, symptoms and ECG findings not usually reproducible with exercise. Brugada syndrome, diagnostic criteria. Major criteria. 1. Presence of ECG marker in structurally normal hearts. 2. Appearance of ECG marker after administration of Na plus channel blockers. Minor criteria. 1. Family history of sudden cardiac death. 2. Syncope of unknown origin. 3. Documented ventricular tachycardia/fibrillation. 4. Genetic mutation of ion channels. Brugada syndrome. Treatment. Implantable cardioverter defibrillator, ICD. Symptomatic with the disease, ICD. Asymptomatic with family history of SCD, with normal ECG observe. Asymptomatic with prolonged HV interval and inducible VT/VF, controversial ICD. Potential antiarrhythmic drugs in Brugada syndrome. Quinidine, non-specific eye blocker. Isoproterenol, open L-type calcium channel. Cilostazol, augment ICA. Conclusion: sudden cardiac death in Southeast Asia. Characteristic ECG pattern, Saint elevation in V1, V3. ICD implantation in symptomatic patients.